Okay guys, so in this video we will discuss about diabetes in pregnancy. This is one of the most common disease in the pregnancy. So there are few things that we are going to discuss, which is the epidemiology, types, screening and diagnosis, complications and management. So in WHO 2006, more than 180 million people have diabetes, and this number is likely to double by 2030. It is worrisome to us. In Malaysia, diabetes prevalence among adults more than 30 years of age has increased from 8.3% to 14.9% in 10 years apart, and diabetes admission based on type of diabetes represent 30% of the total emissions. So there are two types that we are going to discuss here, which is a pregestational diabetes and also gestational diabetes. So pregestational diabetes means that you have already have been diagnosed with diabetes before the pregnancy. So either you are insulin dependent or non-insulin dependent, or either you are on diet control or on hypoglycemic agent or insulin therapy. Regardless of what treatment and what kind of whether it's insulin dependent or non-insulin, you are classified as pregestational diabetes if you already diagnosed before the pregnancy. So there are methods and criteria for diagnosing diabetes mellitus. If you have symptoms suggesting of diabetes mellitus such as polyuria, polydipsia, peripheral neuropathy and unexplained weight loss plus polyphagia with the results of the random blood sugar more than 11, fasting more than 7 and 2 hours more than 11, you are diagnosed with diabetes mellitus. There are two numbers when you start diagnosed to have diabetes mellitus in pregestational, means the normal people. 7 when you fast and 11.1 when you after you eat. So with no symptoms, diagnosis should have at least one additional glucose test result on another day with a value in a diabetic range. So for the WHO recommendation on 2011, HbA1c can be used as a diagnostic test for diabetes. HbA1c is the value that can predict whether you have a good control in diabetes or not. So a laboratory venous HbA1c of 6.5 is recommended as the cut point for diagnosis diabetes. More than 6.5 means that you are not in a good control, and less than 6.5 means that you are in a good control of controlling your diabetes mellitus. So for gestational diabetes, the name itself suggests that this is the diabetes that developed during the pregnancy. So this kind of patient had a higher risk of type 2 diabetes mellitus after the delivery, and associated with increase of subsequent type 2 diabetes mellitus approximately 50% with a woman with a gestational diabetes after 5 years duration. How the pregnancy can induce a diabetic state? So there are three theories behind this, whether it's occur all together or whether it's a standalone. I'm not sure. So basically it's a raised level of progesterone and estrogens promotes gluconeogenesis, and also the placenta itself begin to secrete human placenta lactogen that will decrease the insulin sensitivity, and also the human placenta lactogens in the placenta promotes lipolysis and increase the concentration of the fatty acids, causes insulin resistance. So this is the pathophysiology. The three, I'm not mentioned the pancreas. Yep. So high steroid, sex steroid hormones such as estrogen and progesterone promote lipolysis, increase in free fatty acids. So the glucose is spared for the fetus and increase the maternal blood sugar. It's the same with the placenta and also the pancreas. This will promote all the insulin resistance and gluconeogenesis, which causing the increase of blood sugar. So why the diabetes in pregnancy is very important, very crucial for us to know, to realize, to diagnose as a doctor, to diagnose, especially because the complications to the maternal and the fetal is very bad. Okay, so for the maternal sides, for the mother sides, during the antenatal, the mother may have to have preeclampsia, polyhydramnios. Preeclampsia is the condition when your blood pressure is not controlled, and then the polyhydramnios, the increase in the volume of the amniotic fluid, and if the sugar is not controlled, you can have diabetic emergencies where the sugar may become very high or very low. So if very high, you can get that ketoacidosis or diabetic coma, and it's very low, you can get hypoglycemia. And as the other diabetes mellitus patients, you also had end organ damage, and for this in pregnancy also, because of the high glucose, it may lead to urinary tract infection, and probably because of the very big baby, you need to have operative delivery and probably spontaneous abortion. So for the fetal, for the complication for the babies itself, the baby will become big, and sometimes the baby will become too low, too small. Delay organ maturity for the babies, and there are studies that show that the babies may develop congenital abnormalities, and during the labor and delivery, because of the patient may have preterm labor or prematurity and birth trauma, especially shoulder dystocia if you deliver the baby vaginally, and metabolically the baby may have hypoglycemia, hyperbilirubinemia, and polycythemia.